Hello and welcome. On behalf of CME Outfitters, I would like to welcome all of you and thank you for joining us for the first in a series of 3 CMEO snacks. And the first one of these snacks is titled Dengue Disease Update. What do US clinicians need to know? This CMEO snack series is supported by an independent grant from Takeda Pharmaceuticals in US. My name is Marco Aurelio Safadi. I'm an associate professor and currently the head of the Department of Pediatrics at Santa Casa de Sao Paulo School of Medical Science here in Brazil. And I have the pleasure to be joined today by a distinguished colleague, Dr. Inês Esquilin Rivera. Dr. Esquilin Rivera, could you please introduce yourself?
Hi, how are you? My name is Inês Esquilin. I'm a professor at the Department of Pediatrics and the director of the Pediatric Infectious Diseases Division at the University of Puerto Rico School of Medicine in San Juan, Puerto Rico. It's a pleasure to be here with you, Dr. Sadaf.
So nice to have you here, Inês. Well, to frame the discussion today, let me review our learning objective. Our goal today is that after this CME snack, you will be able to identify the clinical manifestations of dengue disease, factoring in exposure risk. We know that in many parts of the US, dengue is not common. So probably most of you have never treated a patient with dengue or know someone who has ever treated a dengue patient. So the idea, we really want to start our program with an interview. And in this interview, we'll have a patient who has had dengue. So you will be able to see firsthand what the disease is like and the burden it places on patients. So let's follow the video.
I didn't know I was gonna get sick because I had my day going normally and I didn't have signs that I remember, right, of any blister, any mosquito bite, nothing. But it didn't cross my mind really. So that dengue was the thing I had was like really a shock. I was like really tired. It was something like 10 a.m. and I just had woken up. So it was weird that I was feeling that tired. One moment to another, I started to feel body ache and headache. And it persisted, even though we administered Tylenol or even Advil, but nothing helped. And during that night, I think I had 102 Fahrenheit fever. When my mom saw that I had 102 Fahrenheit fever, she kept me in observation that night, and she said, if in the morning you're not feeling better, we're going to the hospital. But in the morning, I started to see black spots on my eyes, and it was really weird, and I lost my appetite. The fever never went down, and since the appearance of the black spots on the eyes, she decided to take me to the hospital, and there they administered IVs and had my blood tested, right, and get COVID tested. They didn't do dengue because it didn't cross their minds, because I had all the symptoms of COVID, and for them it was COVID. That test of COVID came negative. So they sent me home after giving me IVs and giving me something for the upset stomach. Even though they gave me those IVs and the medication for the stomach, I still had the fever, had the body ache, headache, everything. And that night I felt worse. And the shivering was horrible. As the fever, headache, and body ache persisted, my mom said that the best option was to get me to the hospital again. But there they did administer the test of dengue, where they found out that my platelets were at 5,200. They kept me in isolation for 5 days, and the abdominal pain was worse because I was super tired and I didn't have the strength. I felt better on the 6th day, but that was the first day I felt like energy.
Very interesting, Inez. That was a really eye-opening experiencing the patient provided to all of us. So let's keep her story in mind while we dive into our program today. So let me start, Inez, and let me talk about dengue prevalence. What can you tell us about dengue presence around the world?
Yes, absolutely. Dengue causes the greatest human disease burden of any of the arboviruses, with an estimated 40,000 deaths and 100 million symptomatic infections per year across 125 countries. Almost half of the world's population, about 4 billion people, live in areas with risk of dengue. I would say that among the 250 countries and territories considered globally, 86% are potentially suitable for the existence and development of the Aedes aegypti and the Aedes albopicus mosquito, which is the vector of dengue.
No doubt. Dengue is really a major public health concern in several places of the world, particularly in my region in South America, in Latin America, and in general, and particularly in Brazil. Just to have an idea, Inez, we usually have more than 1 million cases per year associated with, on average, 1,000 deaths associated with dengue and thousands of hospitalizations with the disease. And what we are seeing that calls my attention is that we are observing an increasing trend in reporting dengue in several places. Areas where we never reported dengue, we are seeing increasing incidence rates of dengue among travelers, etc. So I fully agree with you. These arboviral diseases of major public health concern around the world. So thank you so much for that summary. And Inez, you mentioned that mosquitoes transmitted the virus. Could you tell us more about this? How does it work, the transmission of dengue?
Yeah, the Aedes mosquitoes are the principal, the vectors of the dengue around the world. There are two species, the Aedes aegypti and the Aedes albopicus. The major vector is the Aedes aegypti. And then it's very interesting how the cycle of transmission occurs with these mosquitoes that love to live around people in man-made containers and in water, standing water, and they replicate very easily. The mosquito will lay their eggs and replicate very easily in water. Sometimes in pots, plant pots around our garden, we do have these mosquitoes replicating. And then there is an intrinsic and an extrinsic cycle for the transmission of this mosquito. And it starts with the mosquito taking a blood meal on an infected person. A person that has dengue gets bitten by the mosquito, and then the virus will start to replicate in the midcoat of the mosquitoes and will go to the salivary gland of the mosquito. And then this infected mosquito will go to bite a susceptible person, a person that hasn't been infected probably with that specific dengue type in the past. And that person will go through an intrinsic incubation period that will last from 5 to 7 days, where the virus will start to replicate, and then a second mosquito will bite that person that is having symptoms by now after the incubation period, and that then the cycle will start again and goes on. And that's why within a household, when there is a person with dengue, mostly everyone in the house gets infected because the mosquito will go from one person to another. And this is very, very common for us in the Caribbean. It's that common that in our emergency rooms and local health centers, if someone comes with fever, our top diagnosis would always be dengue.
No, that's perfectly correct. And regarding the species of Aedes mosquito, definitely the Aedes aegypti is the most competent one, and currently in our region this mosquito is really prevalent around our region. So thank you so much for that nice summary, Ines. And well, now that we talked a bit about the role of these vectors, these mosquitoes, and the spread of dengue, what can you tell us, Ines, about the dengue virus itself?
The dengue virus is an arbovirus, actually a flavivirus. It is a icosahedral, very small, single-stranded RNA virus composed of mainly 3 structural proteins and 7 non-structural proteins. It's very interesting because we always talk about dengue, but there are 4 different viruses. And what is even more interesting is that once you get infected with one serotype, you get immunity to that serotype, but you are susceptible to the other serotypes. And in places like Puerto Rico, where we have all the serotypes circulating, it's very common to have patients that just got dengue 1 or 2 years ago and will come with dengue 3 this year. And it's also very important to mention that the second episode or the second infection of dengue is associated with more severe disease. So that's why it's so important to, even when you had dengue in the past, try to prevent a second infection or third infection.
That's the key point, and very important, Ines. Despite being for closely related serotypes, it's very intriguing, because if you are infected with one of those serotypes, it will induce long life immunity only against this specific serotype that infected you. And after few months, a period where you theoretically has cross protection, but after few months, you again is susceptible for these remaining 3 serotypes that you haven't been so far infected. And very intriguingly, if you have a secondary infection, is usually where we see the most severe cases. But we will have opportunity during our next programs to discuss with a bit more the reasons behind the risk of severe dengue, behind those secondary infections. Usually, the longer is the interval between those infections, the the higher is the risk of having severe dengue as a secondary infection. Very intriguing.
Absolutely.
Well, Ines, we have talked about what dengue is, but tell us a bit more about the clinical presentations. What really dengue actually does look like in a patient who present at the emergency room?
Actually, dengue can range from completely asymptomatic disease to mild or even severe disease. So dengue is a very interesting infectious disease. In 2009, the WHO established a classification system for dengue virus, for symptomatic dengue virus infection. And the first category is dengue without warning signs. And the diagnosis is established when the patient lives or travels to a region that is endemic for dengue, has fever, plus two of the following: nausea or vomiting, a rash, which is usually maculopapular or macular, myalgia, arthralgia, headaches, or retroorbital pain, leukopenia, or a positive tourniquet test. And as you can see, if a patient only has nausea, vomiting, and a rash, or nausea, vomiting, and myalgia, it is very difficult to establish that this is dengue. So you have to be very aware and suspicious about the possibility of this infection in order to provide the best care to that patient. Then the second category is dengue with warning signs. And these warning signs were the most important part of this new classification, because these findings would alert the physicians about the possibility of developing severe dengue. And if patients have any of these symptoms, which include abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation because patient has ascites, has a pleural effusion, for example, mucosal bleeding, signs of mucosal bleeding, lethargy or restlessness, hepatomegaly, or an increase in the hematocrit that is concurrent with rapid decrease in the platelet count. These are the signs that should alert the physicians and the care providers that this patient is going to progress to severe dengue if that patient does not receive the appropriate care. So this is the first part of the classification. Far from these two categories, then we have the severe dengue.
Oh, that's perfect, Inez, and it's clear for me that is WHO new classification and the inclusion of the dengue classification without and with warning signs and the definition of severe dengue clearly helped us a lot in terms of accessing the patient and providing a timely treatment for this patient. It clearly, in my opinion, this classification increased the sensitivity. So it allowed us to really identify earlier the patients who had severe presentation of dengue, and it make us prone to really initiate what, in my opinion, makes the difference in terms of the prognosis of dengue, which is the early identification of shock and providing really hydration that clearly change the prognosis of this patient. So definitely this new WHO classification helped a lot, both in terms of increasing sensitivity, but also in terms of allowing us to really implement a more timely intervention to decrease case fatality rates, etc. Very, very nice. Ines, we talked about this presentation and the patients that go. Could you please elaborate a bit beyond regarding these patients with severe symptoms? How do they behave?
Yeah, severe dengue is probably the worst complication of this disease, and it's the third category under the new classification. And this includes the patients that have severe plasma leakage, leading them to shock. Fluid accumulation with respiratory distress. These are the patients that can develop severe bleeding, and severe organ involvement too. Some of these patients will develop hepatitis, pancreatitis, will develop myocarditis, encephalitis. All these are manifestations of severe dengue. And as you just mentioned, the most important part is to recognize the warning signs and provide fluids to these patients. I always tell my residents that dengue patients died of shock, and it's this plasma leakage and the extravasation of the fluids what kills them. You don't have to wait till they have a low blood pressure, because most of them are well compensated. And when you see hypotension, then they go to frank shock and eventually will die if you are not able to rescue them. So it's important to institute appropriate care as soon as you recognize that there are warning signs.
Yeah,
But
yeah.
that I think probably that's the most important point.
I always say the same, Inez. I used to say to my residents that really what changed the prognosis is the early identification, and it is very clear that we may change case fatality rates if we are able to identify early the patients who are in shock and provide adequate hydration. Patients of dengue, usually they don't die due to bleeding, they die due to shock. So this is maybe one of the most important message that both of us will address during this snack.
It is very important to recognize that they will die of shock. And once they develop shock, we are probably late. We need to recognize them before they are in frank shock, because prolonged shock will definitely turn to death if we don't recognize it promptly. And I will also say that most people will think that dengue will result in complete recovery because they haven't seen patients die of shock. And it is true that after the first phase, that it is the febrile phase that will last 2 to 7 days, then they will progress to the critical phase, and only 1 in 20 of those in the critical phase will develop severe dengue and are more at risk of death, because probably the body and the early treatment will compensate, and most of them will recover, but there is a significant number that will progress to dengue shock and intractable shock. It is important that during this recovery phase, what will occur is that the extravasation of fluids will stop, and then the fluid will become available to the inside the vascular system. The patients will normalize their hematocrit, the platelet count will start to increase, and there will be slow recovery phase where you will see an elevation of the white blood cell count, and things will go back to normal after the diuresis. But if the patient is in shock and continues for a prolonged time with shock, the prognosis is poor, and the patient will be very, very, very difficult to treat and bring back to a normal situation.
Excellent, thank you. Let's move to another point that also for me is very interesting. Well, clearly dengue is very prevalent in several regions of the world, but we are seeing, as we mentioned earlier, that we are seeing increasing regions at risk of dengue. And US is one of the regions that we are seeing cases of dengue. And I assume that probably the real burden is probably very underestimated in US, because I think that most of the physicians are not aware of the disease. they do not think of dengue when they have a patient in front of them. But can you tell us, Ines, which is the current situation of dengue in US?
That's a very important point, but because even for us in the Caribbean, and I'm sure for you in Brazil, there are people that it is hard for them to recognize the symptoms of dengue initially because it's not that specific. But can you imagine if the US where physicians are not seeing so many cases of dengue, but there are cases. Last year, for example, in 2022, there were 750 cases in Florida. But of those, 57 were local transmission because the vector it lives in that state. There were 17 cases in Arizona, 15 travel associated, and 2 locally transmitted in Arizona, 27 cases in New Jersey, 15 in Illinois, and 10 in Maryland. So there is travel-associated dengue in the US, and there is local transmission in some states in the US too. For Puerto Rico, we have travel-associated dengue, but most of the cases are transmitted locally. That's because we have now actually 3 of the serotypes circulating. And this year, so far, we have 126 travel-associated cases in the US, 71 in Florida, probably because a lot of Floridians come to Puerto Rico and travel. There is what we call a bridge between Puerto Rico and Florida, 9 in Massachusetts, 7 in California, 6 in New York, and 33 in 18 other states. So far we've seen dengue in the US associated mostly with travel, but also local transmission. And so far in Puerto Rico, 256 dengue cases reported, and these are the cases that are symptomatic. I will say that in children, so many cases of dengue are not diagnosed because patients just present with a rash and a febrile illness, and if they don't get tested, we miss the diagnosis. And it's very common in infants to have viral febrile illnesses, and not always people think of dengue.
Yeah, it's definitely probably very likely that we are underestimating the real burden, and it will be very interesting to have some seroprevalence data studies to really address and recognize the real picture of dengue in determined regions of US like southeastern and some territories, etc. But Ines, tell me a little bit more about the age distribution of these cases. Where do you see most of the cases? Where do you see the highest case fatality rates and risk of hospitalizations? Bring me an update of the situation in US, addressing very briefly these points.
Yeah, dengue is endemic in 6 US territories and the freely associated states, but Puerto Rico has the largest population among the territories where dengue is endemic. The highest case and hospitalization rates will occur in children between 10 and 19 years of age, but the highest mortality rates will occur in adults aged more than 20 years of age. So we see dengue cases in the different age groups, so definitely mostly in pre-adolescents and adolescents, and the mortality above 20 years of age.
Okay, well, definitely. We are seeing different pictures in our region, but we are endemic for a long period, and we currently, the age group where we are seeing the highest case fatality rates and death recently in Brazil are the elderly group. We are seeing increasing hospitalization rates and mortality rates among the elderly in our population, which is obviously brings the need to discuss how to also protect these age groups. But let me move to another point regarding also the epidemiology in US and the mosquito distribution in United States. Does the range of mosquitoes in the US necessarily mean greater risk of dengue? Can you address these points, Inez, regarding the distribution of mosquitoes in determined regions in US and associate this distribution with the risk of dengue in United States?
Well, yes, the vectors are mostly in the south and the eastern coast of the US, and there is a model that uses county level records, historical records, and the suitable climate variables to predict the likelihood that mosquitoes will survive and reproduce, but this doesn't necessarily represent a risk for spread of the disease. We just know where the mosquitoes live, where are the climates and the temperatures that are more avid for the growth of the mosquitoes, but this doesn't necessarily represent risk of spread of disease.
Perfectly. And we are currently also, as we have discussed that previously, but we definitely are seeing an increasing number of countries reporting dengue, also in not only in the North America, but also in Europe. Recent data is showing that we are seeing an increasing number of regions in Europe at risk of dengue. And could you briefly comment, in your opinion, Inez, what is affecting this growing risk and what this means in the long term?
Well, yeah, sure. The situation in Europe has to do with the warming trend and frequent flooding that is becoming more frequent and severe, that the summers are getting longer and warmer, and all these predispose to the spread of dengue. In 2013, the Aedes aegypti mosquito was established in 8 European countries with 114 regions being affected. And now this year, it is established in 13 countries and more than 300 regions. So I think that it has to do probably with climate changes and temperatures in Europe. And there was a very interesting paper in Nature Microbiology that made some estimates of what can probably be happening in the future. And they estimated that 2.5 billion more people will be at risk of dengue in 2080 versus 2015. And most of the southeastern USA was predicted to become suitable for dengue in 2050. And this is driven by climate change, by urbanization, by population growth in endemic areas more than anything else. But I was surprised when I look at that data because for us that we will need to be aware and work hardly on getting some public health measures to stop the possible epidemics if the situation goes under control. Doesn't go under control.
Yeah, no, excellent. Well, I think we are coming to the end of our program. Thank you so much, Dr. Esquilin Rivera, for this wonderful conversation, for this wonderful program. I hope our audience has learned about a topic that probably they are not familiar with in the United States. So let's now go over our SMART goals. that we hope our audience has accomplished from participating in this program. So we have several bullets that I will address. The first one is to develop foundational knowledge of dengue, including global prevalence, viral characteristics, and also mechanisms of disease transmission, as well as identify clinical presentations specific to classic dengue and also severe dengue when considering differential diagnosis for patients at higher risk of this disease. Characterize the prevalence and the risk of dengue disease specifically to the United States, including projections of increased risk when discussing infectious disease topicals in your clinical practice. Well, this CMEO snack is one of a three-part series. We hope that you will take advantage of all of the short and focused activities in this three-part series. Well, again, Dr. Esquilin Rivera, thank you so much for joining me today. And thank you all for participating and providing the best care for our patients. Thank you so much.
Thank you.